Adrienne Teske is a second-year medical student at the University of Calgary with a background as a registered nurse, both in urban acute care and more recently in primary care in northern Alberta. Her clinical and lived experiences in rural and remote communities have shaped her commitment to rural family practice. She is passionate about advancing equitable health care access for rural, remote, and Indigenous communities across Canada. Please come up and share with us, Erin.
So I'll jump right into it. But failures in transport systems don't just delay care. They reshape clinical decision-making, they strain providers, they fracture families, and reproduce inequities, all of which have already been spoken about in under 2 hours of this conference. So these ideas are not new, and these themes are often repeated. However, today I can only speak about my experience from the perspective of a rural nurse. So some disclaimers before I begin. I have no financial or biases presenting at this time. I also want to be explicit about confidentiality, particularly because I'm speaking about care provided in such small and remote communities. What I'll describe today are composite scenarios drawn from real clinical experiences. Details such as timing, patient age, family structure, and specific events have intentionally been altered or generalized. The purpose of this approach is not to tell patients specific stories, but to describe recurring system-level challenges in pre-hospital and retrieval medicine. Additionally, I want to just say that all pictures you see today have been taken by myself or another nurse from this community to share both in its beauty and its challenges. So prior to starting medicine in Calgary, I worked in a community as a primary care nurse, and it was called Fox Lake, Alberta. It was part of Little Red River Cree Nation in northern top corner, just kind of on the edge of the territories. This community is predominantly fly in, fly out most of the year, allowing for seasonal ground transport via barge or the ice road. I worked in a nursing station where we didn't have an x-ray, we had minimal point-of-care labs, and never a doctor. We had the wonderful support of paramedics at times and a nurse practitioner. Additionally, as was previously mentioned, most of community response was done by family members, and we had limited response at that time. Nearly all emergencies that we saw had to be medevaced out of our community, and that was roughly an hour flight away. However, there were barriers that impacted this capacity daily. This means that in practice, rural clinicians are constantly assessing not just the patient in front of them, but whether the system will be able to respond at all. Since I can only speak about my time as a nurse in Fox Lake, I'll describe some scenarios based on real events that would happen more often than desired. And I'll go into more detail about the barriers that exist to that transport and access in remote communities. The common four that you've heard today are geography, competing system resources, policy constraints, and what happens after the emergency is technically over. These barriers don't occur sequentially. They overlap, they compound, and they often present at the same time. So on this slide, this is our main road out. As you can see, it is the ice road, and it is seasonal. Here it is spring, and parts of the ice are starting to break away, deeming it no longer safe to cross. And the barge, it won't run until all that ice is gone. So with the ice road and multiple variables impacting flight capacity in this community, there is often no transport in or out. For clinicians, this turns geography into a clinical value, sometimes as important as vitals or labs. The physical isolation isn't just a backdrop, though. It actively shapes clinical decision-making. To show what this looks like in practice, I want to share a few scenarios. So I want to take you all to Fox Lake. And you have an unstable patient brought into your nursing station. It's immediately clear that a higher level of care is needed than the resources you have available. You call the nearest hospital, and for those who don't know, in Alberta we have a system called Rapid that helps coordinate all flights. So you call Rapid, and you ask for a medevac out of community. You can look outside your station and see that the weather is clear, there's no snow or rain. You drove past the runway this morning on your way to work, you can see that it's clear and well lit. But you're informed by Rapid the pilots have hit their mandatory cap on their flight time. They won't be in the air for the next 8 hours. However, Rapid does offer you an ambulance. It's in a community 2 hours away, and they will not take your barge to get to your community. So now your team needs to coordinate with your one emergency response vehicle and your advanced care paramedic to transport your patient across the barge. During this time, it will leave your community without an advanced care paramedic and an ambulance for the entire duration they're gone. Additionally, it's spring, so the roads look like that on your right. And furthermore, you know that once they get across the barge, you'll lose all cell service, so they won't be able to communicate with you or each other. Now you have to decide. Can you keep this patient for 8+ hours in your nursing station, or do you send them by land transit? This routine decision point in rural and remote healthcare, choosing delayed definitive care and unsafe transport, knowing you are accountable either way. Sometimes you're left with uncomfortable and imperfect choices, one where neither is ideal, and leaves the care of the patient delayed or subpar based solely on the resources present. This is where moral distress comes in and becomes routine, knowing what right care is, but being structurally unable to provide it. So one community facing an emergency is difficult enough, but in Northern Alberta, and probably BC too, no community's emergency happens in isolation. Rural clinicians are acutely aware that advocating for their patient may delay care for someone else. Planes pilots and paramedics were shared across multiple remote communities, meaning that every urgent call competed with one another. And when 2 emergencies happen at once, the system showed its limits. So I'm bringing you back to Fox Lake. The sun is shining, as it often did, even at -30. The sky is clear, but the ice road is melting and is unstable, so no road transit today. You have an emergency brought into your clinic, and they need transport out, so you call Rapid again. And you find out a code red has been called in your neighboring community, meaning all resources have been shunted to manage the situation there. This could mean for you that you are now down all planes, or you don't have the emergency personnel you need to transport this patient, or you're scrambling to negotiate scarce resources with them to find solutions until safe transport can be provided. In these moments, clinicians aren't just providing care. They're coordinating transport, interpreting policy, and managing system failures in real time. Sometimes this can look like staying on a call with a physician in the nearest hospital, following their guidance to stabilize your patient until more help can arrive. However, if they are in the nearest community, they're about to get overwhelmed with the incoming patients from the nearest neighboring community. So even if conditions are perfect and all staff are where they should be, there is still competition for limited resources that exist, further delaying care and forcing staff to provide care that is out of their comfort zone until further help can be achieved. This expansion of role often happens without additional support, authority, or protections. While logistical barriers are much easier to imagine, the more discrete but equally challenging policy barriers exist and form their own sources of obstruction. There were large systemic barriers that existed to transport and access in a primarily Indigenous community, which Fox Lake was. These barriers have historical context to them and make them that much more frustrating when encountered because there should be a better way. For some context, in this community, the cost of medevacs were covered under the non-insured health benefits. And for those who don't know, to be covered under the NAHB, you have to be a First Nations person who is registered under the Indian Act, an Inuk recognized by an Inuit Slam Claim organization, or a child less than 2 whose parents qualify for the NAHB. As well, there's one quote I pulled directly from this NAHB that I want you to remember for a later situation, is that they aim to provide the most economical and efficient means of transport is used, taking into consideration the urgency of the situation and medical condition of the client. So on paper, these policies are meant to ensure fairness and efficiency. In practice, they introduce administrative decision-making in moments of clinical urgency. With that being said, you now have 2 young patients coming into your clinic in need of evacuation to a higher level of care. Your patient 1 is an Indigenous 2.5-year-old with no active treaty number. As you may recall, they are no longer covered under their parents after the age of 2. Your second child is a non-Indigenous child who doesn't qualify for the NHB in the first place. Now, on paper, this should not be a problem, and immediate care should be provided while finances can be worked out later between governing bodies. However, this did not always happen. Sometimes it fell on the healthcare providers and families to advocate and push for these children to receive services and worry about finances later. These barriers can provide and do provide delay in care. They put stress on the family and healthcare providers as they search alternative coverage with the threat of paying for these very expensive planes out of pocket. If we could find ways to create policies that allow flow of patient care without immediate need for coverage, such as that of Jordan's principle, as I tried to do, we could provide a small peace of mind for all patients experiencing this level of care. The stress here isn't just emotional, it is ethical. Clinicians know that delays created by coverage uncertainty can worsen outcomes, yet they have little to no control over the policies that create these delays. And thank you, Erin, for talking about this. The last topic I'll mention is one that anyone who's worked in remote community is familiar with and knows the controversy that comes along with it. So it is generally expected that women in remote communities are transferred to larger centers to give birth at 36 to 38 weeks gestation. While the NHB allows financial coverage for an escort of the pregnant patient, they often do not allow children who are not fully dependent to join. There's no coverage for childcare or extra support for these children who are not able to go with a pregnant patient, leaving these mothers to make a very difficult decision. And clinicians are left supporting these decisions while being a part of a system that has created them. Many choose to stay in community until they are in labor because of these barriers, which is more than understandable. However, in an understaffed and under-resourced nursing station, an uncomplicated delivery isn't always expected, let alone one that might be higher risk. When these barriers intersect, transport, policy, and family separation, the consequences can escalate quickly. The next scenario will bring all these elements together. So, for the final stretch of your imaginations, your last patient who comes in is in active labor. They're 39 weeks gestation, but the baby is breached. They have 2 kids at home over the age of 2, with a partner now having to choose between childcare or accompanying that laboring mom. Thankfully, though, the planes, the paramedics, and the pilots are all available and transport the patient to the nearest hospital for an emergency C-section, delivering a beautiful, healthy baby. And now this is where I want to bring you back to that quote I had mentioned earlier, that the NHB only provides the most economical level of transport depending on the level of emergency. So now your patient is discharged from the hospital post C-section without a partner and a newborn to take the bus for hours back to community. I want to use this example to highlight that even when the emergency transport aspect is well managed and everything falls into place, the post-emergency care back to community can be equally as important. It leaves patients in vulnerable, painful, and sometimes risky situations when being repatriated back home. The system defines success as arrival at tertiary care, while rural clinicians witness the harm during discharge, transfer, and reintegration. From a clinician perspective, the system defines success far too early. I was born outside my own rural community because the hospital did not have necessary resources to support my birth. But I was fortunate enough to live in an area where a major highway connected my family and I to a tertiary center. While most rural communities are often underserved, not all communities are created equal in access. I know equality of access may not be possible, but improving on and building upon what we have to bridge the significant gap might be. These examples all differ in detail, but they share a common thread. They're not rare events. They're predictable outcomes of how retrieval and coverage systems are currently designed. So I don't want to say all is lost. We do have some strengths. When everything falls into place and all the planes and paramedics are available, the system is potentially as fast as it could be to get patients from a remote community to a higher level of care. The medevac system is a great part of that, and as well, the NIHB coverage does allow a lot of financial assistance for patients. And I can't forget about the amazing staff who live and work in these communities. But they are up against some significant challenges, including flight caps, weather dependency, limited staff and equipment, competing resources, and incomplete coverage policies, all of which, as we've seen today, impact patient outcomes, leaving them delayed or suboptimal, stress and moral distress for healthcare providers, family and community burden, and inequitable access. If challenges are systemic, then solutions must be too, and that's where hope comes in. I want to be clear. The communities I spoke about are resilient, and so are the clinicians who work in them. But resilience should not be a requirement for safe care. The current experience of rural pre-hospital and retrieval medicine relies heavily on clinicians absorbing risk, clinical, ethical, and emotional, to compensate for system gaps. A meaningful way forward is not about asking rural providers and communities to adapt further, but about redesigning systems so fewer workarounds are needed in the first place. This can include coverage policies that delay default to care first without real-time eligibility barriers, clear, reliable communication between rural communities and retrieval services, and planning not just for transferred out, but for safe and supported return home. These aren't radical ideas. They are practical changes that align systems with how rural care is already being delivered, just without forcing communities and clinicians to carry that burden alone. The image you see behind here is of the wild horses just outside the clinic windows. These wild horses return every year to Fox Lake, even after the wildfires come through almost annually now. They return not because the conditions are ideal, but because the land remains home. Rural communities will continue to show up for their people, and our system should be designed to show up for them as well. So I'm thrilled to be a part of what's being discussed here, as this has been something that has been on the back of my mind for quite some time. And I want to thank you all for your time and expertise, as well as the future speakers here today. And thank you to Dr. Ritchie for inviting me. I believe together we can empower communities and expand that access. Thank you.